Okay, good afternoon, everybody. So I'm going to start off before the CEO comes in. It's a great pleasure to have Professor Sanjay Asrani here with us today. And he is a professor of ophthalmology at Duke University and the medical director of the Duke Eye Center at Cary. And he's also the head of the glaucoma at Duke Reading Center. So he's a glaucoma specialist and specializes in glaucoma treatment and cataract surgery, very skilled surgeon and glaucoma surgeon. And his specialty is really imaging and the ability to detect glaucoma and its progression in early stages, and has been instrumental in many of the developments related to OCTs. He's board certified ophthalmologist and fellowship trained from Duke Eye Center and as well as Wilmer Institute at Johns Hopkins. Has received multiple awards, including a Career Development Award from the Research to Prevent Blindness Association, the Helen Keller Award from the American Glaucoma Society, Best Doctors in America, America's Top Ophthalmologists, the Senior Achievement and Secretariat Award from the American Academy of Ophthalmology. He's as well as a dedicated researcher, received support from the Research to Prevent Blindness, private foundations, and philanthropy. His major research interests include the development of new surgical implants for glaucoma and the development of new technology for the early detection of glaucoma. So without further ado, please join me in giving a warm welcome to Professor Sanjay Asrani. So, Dr. Asrani, I'd like you to start off and maybe tell us a little bit about yourself and how you started your career in ophthalmology and your path to leadership.
Thank you. Thank you, Deepak. Thank you for the very kind introduction. Your CEO asked me to possibly try an alternative method of chatting rather than giving a talk. So that's why we are sitting here and giving a talk. So since I'm not standing up, I can barely see the tops of the heads of the other people. So please feel free to come forward. We are going to make this a chat. We are going to ask you to give us feedback, me feedback as to what I can experience while I'm here. And let's make it an interactive discussion. So to answer Deepak's question as to how did I end up where I am today, I just followed the leaders and I followed Deepak's path. Deepak did residency and was already a faculty member when I came to the US, and I came as a research fellow to the US. I did not have the requisite visa, so I worked in research for 6 years and then got the visa to transfer over to get a residency. Then I restarted my residency, just like Deepak did. I restarted the residency, did my fellowship, and then stayed on at Duke University. And the reason I stayed on at Duke University was something that was unique, and that I'd like to share with you. I was getting offers of payment, salary, or income from private practice, which was giving me almost double than what Duke was offering. And there was a very big question among a lot of my colleagues, my friends, my family. It's like, why are you taking that job? That job is paying you half of what your income could be. But there was a reason. I had seen that in private practice, a lot of people got burnt out, in the sense within 5 years, they felt hollow. They did not feel like they were doing anything unique, anything special. They were just seeing patients, churning out money, going home. They were getting the satisfaction of treatment, but their intellectual curiosity was not being satisfied. And there is no alternative to intellectual curiosity. That is what keeps the brain active. And as my chairman always said, that if you go out into private practice, you're going to come back in 5 years knocking at our door saying, let me do some teaching, let me share, because when you see things interesting in the clinic or in the patients or in the surgery and you want to share it, you have nobody to share it in private practice. So I stayed on because I wanted to be around people where there was intellectual curiosity. And ultimately, at the end of the day, everyone earns enough to have a good life as a doctor in any country. So I decided, okay, I'll just stay back at Duke. One of the biggest reasons was my colleagues and my chairman. Chairman had a vision. We were in a eye center building of 3 stories. We had 3 operating rooms. There were only 12 consultants. This is the year 1999. 12 consultants, 3 stories, 3 operating rooms, and our waiting lists were full. All the consultants were very proud of having a long waiting list. And our chairman realized that this is not going to be financially viable. The other thing was the reputation of Duke University Eye Center was that you come to it only when your things are so bad that nobody in the community wants to handle your case. And if that was the case, only then were you sent to Duke. So what we would get was what we call train wrecks. That is, the eye is almost lost and then they sent to the eye center. Now what happened is that we had to do various kinds of surgery, combined surgery with different subspecialties and try to rehabilitate this. But what we did not see was the glaucoma suspect, was the early strabismus that you could treat. We did not see these easy cases. So for each of these cases, when they came to the eye center, it would take 2 to 3 hours to have them seen, to do all the testing, to plan all the treatment. And they would be coming from far, so you do everything on that day. So the reputation became that if you came to the Duke Eye Center, you couldn't leave for at least 4 hours. You were stuck there. Because it was in a city of the Durham city, which had at that time a very poor reputation of safety, nobody wanted to come to Durham. Also, you had to pay for parking. So that was another big hassle. And people would just not come. So our chairman had a vision, and the vision was, we need to go where the people are. We need to go into the community. And we need to take care of the easy cases also. We need to share with them how we are able to help them. The community was up in arms. The Duke Hospital CEOs was up in arms. He was like, you're going to go out there into the community? You will spoil our relationship with the referring providers. They won't send the patients over. And you will cause a big problem. So don't go. But our chairman said, okay, on my own funding, I want to start a clinic. And we chose a zip code where there were well-to-do patients who were up and coming. That is, small families. And we started what is called the first satellite clinic. There was no example of a satellite clinic previously. We started with 3 lanes, 1 doctor. No community doctor wanted to send their patients because they were afraid that we would swallow their patient and they would not get their patient back. So I went out and met with each of those referring providers, reassured them that I am going to send your patients back and I'm going to help you manage your own patient. You are not going to lose the patient. I will help you when you are stuck, when you don't know what to do next. You want a second opinion. And slowly, slowly it started coming. And we are now about 7 doctors, about 110 patients a day. That is 2 doctors a day. And we see at least about 50 to 60 patients each. And we have a clinic with the technicians and the photography. Now, what we ran into was another unique problem, and that is that the technicians would want to be attached to a particular doctor because they would get familiar with that doctor. The problem was then they only knew the testing that that doctor did. They did not know the testing the other doctors would do. And if one technician did not come one day, this technician was not able to fill the gap. They also started complaining that that person's working less and this person's working more and this. And so we came up with a system that we started at Duke where, because of the electronic medical records, we could see what time did the technician take the patient, what kind of patient was taken, new patient, return patient, how many testings were done by that technician, all the tests that were done. And at the end of the day, the computer would tally. So there was no way a technician could say that somebody else is working more and somebody else is working less. We also changed everything. We gave the technicians a room. Instead of giving the doctors all 5 rooms, we gave the technicians the room and told them, this is your room for the day. You work up the patients. So they worked up. I have 2 or 3 optometrists who are technicians working with me. They do everything: vision, pressure, pachymetry, history, and testing, OCT, visual fields, everything. It is the patient and the technician have now a complete relationship. The patient's behavior is shared with me. When the patient is put into my room, patient is confused or is weak or is not feeling well, all those extra things. And then I go and see the patient. So we are now 8 satellites of the Duke Eye Center. We were the first satellite of any field. Since then, Duke has now 200 plus satellites in different fields. Because now we have the courage to go out into the community. Now we have the ability to see the patients within 60 minutes of their arrival, they are out of the door. So the reputation has improved. Plus, new patients are coming in that are never would have seen the Duke hospital system. So I just wanted to share that with you as where we are right now compared to where we were. We had to branch out. We had to take the lead. We are currently seeing about 55, 60 patients a day per doctor. We start at around 7:30, 7:45 in the morning, and we end around 5:30 or so. One technician waits, whereas every other technician goes home, so that in case a patient needs a test or something, there is a technician available, and that technician by rotation waits. At 5:30, when all the patients are gone, we sit down with the residents and the fellows and go over each of the cases that we saw in the day. And that allows us to be able to teach them and share with them why we made the decision we made. And they have an option of asking us, but what about this possibility? How about this thing? Why couldn't we do this? And sometimes there is actually a very interesting idea by the residents or the fellows that I'm able to utilize. And I call the patient back and say, we were discussing your case and we found that we could do something totally different. And this idea came from my fellow. And I think it's a very good idea, and we are going to do that. This gives the residents and the fellows a sense of pride, opportunity, that they are contributing, making differences to the patient's care. They are not just cogs in the wheel working. And they then also have these lectures which start at 7 in the morning, end at 7:45, or 6:30 in the evening and end at 7. So we have academic lectures, but during the day we do the clinic, and at the end of the day we do the what is called chart rounds. We go over the patients. What we don't have is the dedication that I saw yesterday. I was amazed by the dedication of the personnel here. I was in the clinic, I think, with Dr. Al-Ubaidi, and I saw 2 very well done Goldman visual field tests, which was something that is a rarity, is something that very few people can do. And I asked him as to why did you get Goldman? Why not a Humphrey visual field? He's saying the technician must have tried the Humphrey visual field and realized that the patient is not performing well, and stopped the test and took the patient and decided to do a Goldman visual field. That is amazing. That dedication to patient care, where the technician could have just said, patient not able to do the test, which is what they do in our place. And then we get a test, patient unable to do the test. Here, the technician took the initiative to do a test that was much more difficult, much more time consuming, and did it for the patient. That dedication is amazing to see. You also have a wealth of instruments, and the wealth of instruments that are around you, and the top of the line instruments that you have the ability to use at a very high speed. And because the patient doesn't have to travel from one building to another building, you have the instruments in different buildings, and that is a very good thing. What we realize is that we can also participate in clinical trials, and you can do the same here in clinical trials, because various pharma companies, various surgical companies, they want to be associated with big institutions and be able to share that, we did this trial in this institution, and this institution has repute of good data, good studies, and reliable information. And that is something that we strived to achieve at Duke, and I'm sure you can do it very easily here. We don't have all the instruments in all the locations. You have the instruments here in different. You have got enough OCTs in glaucoma and in retina. So you can easily do the trials. You got endothelial cell count machines, you got MRIs, you got everything. It's just amazing. So I'm impressed by not only just the facilities, but also the dedication. The resident and the fellows teaching. I mean, to have how many? 10 residents?
10 a year.
10 a year? That's amazing. That's a lot of residents. That means you're training almost everybody who's going to be in the kingdom as well as in the surrounding countries. You're going to have a legacy that I'm just amazed. What I also am happy to see is there is a lot of potential for cross collaboration. There, just in the OR, just this morning while I was waiting and watching the surgery going on, I was able to give 2 or 3 tips. Oh, you can hang the tube this way you can push this with a different instrument, you can do this. And that kind of cross discussion is something that is going to happen just informally. It's not going to happen through a lecture. And that is why when I saw my schedule, being in the OR, being in the clinics with different subspecialists, I was like, this is what I want. It's not just lectures, because lectures I give to you. I also am learning a lot by watching people in the clinic, in the OR, and I'm going to take back that to my clinic, my practice, and hopefully we'll be able to offer the same to you. So you come there, you watch, you learn, and we have had people come from Japan, we have had people come from Korea. 5 or 6 doctors will come at one time. We have 15 glaucoma specialists in our department. They will go and spread out among the different glaucoma specialists and see them and watch their surgery, watch their post-op. They're there for about 10 to 15 days. And then we have discussions like this. So that allows us a lot of cross-collaboration, which I'm sure we can do with your institution too. Now, I've been doing all the talking.
Well, thanks a lot, Dr. Asrani. So before we open up the floor for questions and chat, you talked a lot about mentorship and leadership vision. What advice would you give our young, colleagues about mentorship and leadership? Your words of advice.
Some words of advice for leadership is that I would say that first, be true to yourself. That is, ultimately, you're going to have to face yourself in the mirror before you pass away. You have to be true to yourself. You have to have that satisfaction that what I'm doing is right, and I'm doing what is right for humanity. You also have to have a vision. Have a vision not for the 1 year next year, but for the 5 years. You have to imagine what is happening. Like in the city of Riyadh, what I'm hearing is that the traffic jams are tremendous. What does that mean? That means a lot of people are coming to Riyadh to settle down. That means the demand for eye services is going to be tremendous, if it is not already. So we have to have the vision to expand and share this talent to different communities around Riyadh, because there's not going to be easily able to travel to Kekesh. So maybe branch out like we did. Yes, nobody was willing to branch out. Nobody. Because all the doctors said, we are in an ivory tower. If the patient wants to come to see us, they have to take the trouble to come and see us, because we are important. And that attitude had to change. And that was the vision of our leader, that no, we are not that important. We are here to serve. And therefore, we branch out. So, vision, true to yourself, and at the end of the day, you have to have that mental satisfaction that what you did was helpful to humanity and true to your values.
Thank you. Any questions from people on the chat?
Thank you, Doctor, for your talk. I just have a question.
Mm-hmm.
Apparently, you started with saying that you had an offer where you had doubled your salary, and then you stayed at Duke because of it satisfies you from intellectual point of view. And I can see that even the administrative position that you have taken is not because of the status of having administrative position. It has something that you haven't said, but lies behind that position that you have taken, or the leadership role that you have taken. So if you can elaborate, why did you go into the path of administration and leadership? It would be helpful for us to know.
If I'm understanding your question right, is why did I take up the administrative role?
Yep.
That role that I'm in?
Yes.
Yes, first of all, that satellite, the first satellite of Duke or first satellite of any academic medical center was where we started in Cary. So that was my baby. So I had to take care of it. But what I realized was that the bigger we grew, the people who were at the levels of reception, making appointments, triage phone calls, technicians, were not feeling valued or important. And I realized that because we get the satisfaction as the doctors, but the technicians, for them, it's routine. Same thing, same thing, same thing. Front desk, very standard, come in, check out. It gets boring. Just like how I did not want to get bored in private practice. I wanted intellectual stimulation, and there is no substitute for that. I realized that intellectual stimulation is required for all of them. And it shouldn't be mandated. It should be something that comes from the doctors. So there are sometimes days that my clinic ends early. And I'll sit down with the technicians and I'll share with them, you know that patient that you worked up the other day, which you were surprised as to why the findings were so and so? What did it turn out to be? And so this way. Or they are so thankful for the feedback. Like for example, a patient who came in for dry eye. Vision was 20/50 in both eyes. And the technician said, something is not right with this patient. She's not able to walk into the room correctly. She couldn't sit down in the chair properly. I had to guide her. A patient with 20/50 vision should be able to sit down on the chair. But that feedback that that technician gave me was enough for me to diagnose a very fast growing pituitary adenoma. Because the patient had bitemporal hemianopia. That would not have been diagnosed because we would have not done the visual field test. But just that feedback. So I go back to the technician and say, your things, your mention of this saved the life of this patient. And they feel valued. The front desk, the desk that receives the patient and exits the patient, that is, takes them in for the appointment and then makes the appointment for the next visit, is the most critical because they are the face of the eye center. They are the first people who the patient is interacting with, and the last person that the patient interacts with. So that impression of that first interaction and the last impression is extremely valuable. But unfortunately, they are the least paid in our institution. How do I get them motivated to be my face? I need them to smile at the patient when they receive the patient. I need them to interact. How are you doing? Oh, I'm sorry to hear that. How was your visit today? Was there anything we could have done to make it better? That kind of interaction that the front desk would have with the patient tremendously increased our patient satisfaction. And they started writing about the patient experience in what is called the Press Ganey scores, which you very well know. It's among the academic medical centers, and it's now online. And you can see all these comments by the patients online. Excellent, excellent. So that increases the reputation. And now I'm getting patients from Azerbaijan, from Tajikistan, from various Central Asian countries. They're flying in just to see and go back. Why? Because of the internet. The internet patient responses is very valuable. It stems from the front desk. And the front desk also want to learn. So they also sit down with the technicians when I chat with them. You know that patient who left the other day? The poor patient unfortunately had a tumor in this. So they get that human feeling that they also are helping these people. So that is extremely valuable. The website has to be really top-notch, easy, and it should be where the search engines put it on the top. So you have to have the right buzzwords to get it. So you click eye center, and the eye center in that region should pull up first your institution. That is something that an internet expert is certainly able to help you bring it up so the profile goes up, because this is the age of information. What they see in the first page of the search engine is going to be the first impression that they're going to have. So you want your institutions up there, and you have every reason to be up there.
Thank you. Anybody else have questions or comments? Dr. Raji?
Yeah, I have a question. How do you choose the students or trainees that you decide to mentor?
That's a very good question. How do we choose the students and the trainees or the fellows that we decide to choose among the hundreds of applications that we get? We look for those people who have intellectual curiosity. That is the first requirement. If they are there only to come as I just want to increase my skills. As my chairman used to say, for glaucoma, anyone can make a hole in the eye. What's so special about it? The way you make a hole is different, but anyone can do it. Technical skills, everybody has. Intellectual curiosity doesn't come easily to a lot of people. We want that. We want people who have had some life experience, who have been challenged previously, who we know have had their mental resolve challenged in life circumstances. Maybe a refugee, maybe somebody who's had significant family stress but is now seeking an ophthalmology residency. That person has to be commended for overcoming so many odds to be able to come and learn. And those people who have the potential for becoming academic medical doctors, those are a great requirement for us. We want our people to go out there and teach the next generation. We don't want just them to learn and practice. That's also acceptable, but it would be lovely if they would also be able to teach and share their knowledge, share their experience with others.
Any other comments or questions? Sosen? If time takes you back to your first years of residency, with the experience you have now and knowledge, what would you do differently?
That's a very interesting question. This is what I tell my fellows. You will all get there at the end. How you get there is what is important. That is, you will all make enough money. You will all have enough good life. You will have enough resources that you will not be wanting for anything. But how you get there? Don't crush your competition. Don't compete among yourselves. You will have enough opportunity. There is enough surgery. There is enough patients to see. Don't cross-compete with each other. Cross-collaborate with each other. Cover each other. And that is something that I wish somebody had told me when I was a resident. If somebody had told me that, no, you're going to be okay. Don't rush it. Don't compete. Don't look at what is written in the textbooks and see what you're seeing in the patient. Is that matching or not? Because the clinic is the biggest laboratory you can get. There is no replacement of clinic as a laboratory. Who is going to solve glaucoma? Is going to be one astute physician who is going to notice something in the patient and say, but why did that happen? And that curiosity, where you're seeing the patient and you're learning the text also, is what you need to have simultaneously. That's why we have challenged so many of the things that are written in our textbooks, in our papers, and have been taken for granted. But that intellectual curiosity needs to come from within. So my take is that don't cross-compete, cross-collaborate. Don't put somebody down. Enable everybody to go up and have the intellectual curiosity.
This is a very beautiful advice to everyone, actually, not only to the trainees. I used to say to the trainees one thing that I missed doing. We had one colleague who used to do this always, and it was very clever of him. Whenever he sees an interesting case in the clinic, he would go back home and spend an hour or something. At that time, you know, online research was not as easy as it is now. And he would go to the big textbook and read about it, and always link whatever he's read to the patient. And this way, he had so much knowledge within the end of the residency that whenever you talk about any rare disease, he would know everything about it because he linked it with the patient he saw. While what we did usually is listen to the consultant giving us a little bit of information and then probably forget about the case. So that is something I think if everyone does it in the early years, it's very helpful to really remember all the details of the rare diseases. Do you see our profession now switching from being a mission into a job? Like any other job where everything I do has to have a value, financial value and financial gain? Or is the practice of medicine the same?
You asked the question at the same time as my daughter asked this same question.
How old is she?
She is
so I know what level I am at.
She's 31.
Okay.
And years of age, not months. And she did not want to do medicine. Me and my wife are both doctors. She saw our lifestyle. She was like, nah, that's not for me. But when she graduated, she did an MBA, and she's management. She did work for some companies, big companies, Deloitte and so, Kantar and things like that. And when she finished her MBA, they were willing to give her the full tuition back to her, whatever she had spent, if she would take up a job with them. And she said, no, I don't want your money. I don't want your job either. And we asked her, why? You're getting a position with such a big firm. And so she's like, no, Mom, Dad, you both get a satisfaction at the end of the day that you did something worthwhile. I'll be going there crunching numbers to help some CEO make a lot more money compared to the employees. And what satisfaction will I get at the end of the day? You come home, you feel, oh, you know, this patient I saw the other day, I did this and that person got better and so forth. I will not get that satisfaction, and I want that satisfaction. I cannot go on Wall Street and become a number cruncher and earn and earn and earn. There is going to be no satisfaction. In 3 years, I'll be multimillionaire, and then what? Then what? What's there to life? We have a job and a mission. Our job is to work, but a goal is the satisfaction. The satisfaction that we did something for somebody and helped humanity. That that satisfaction is not there in anything but medicine. And we are not going to lose that. We may, in the US, we have become cogs in a wheel. As Deepak knows very well, it's insurances, reimbursements, fighting with the insurance and things like that. It's all money, job. The trust is gone. The trust that the patient has in a doctor. Imagine the trust that somebody is allowing you, which I saw here in the patients here. They have implicit trust in you. That doesn't come easy. That comes only because you're in an institution that fosters that trust. You go out into the private practice, why should the patient trust you? Why? There is no reason. You're a nobody. It'll come from within, being in this institution, because they trust that you will do what is best for them. And that trust is something that the US has lost. We have to have 10 pages of consent form before surgery is done. Because why wasn't this discussed? Why wasn't that discussed? Here, you just say, these are the options we have, and this is what we are recommending to you to do. And the patient says yes. That satisfaction we have lost in the US. You have it here. Capitalize on it. Go home realizing that you have earned that trust, and you're in a mission. Ultimately, what is there in the satisfaction at the end of life? You retire. What have you done? You have done something for somebody. For you, as a patient told me, we may be an individual to you, but you are the world to us. We come here, the moment we enter the building, we feel half of our illness is cured. How is that possible? That comes from this trust, and we are not going to lose that. That mission we have to keep in the back of our minds. However much the job that we have to work. Yes, we have to work. We have to see patients. We are seeing 30 patients in a half day. And we are working till 6:37. Why? At the end of the day, we could go home at 5:30 and be with our families. But then there was no satisfaction because I didn't teach the fellow or the resident all the pointers that he missed or what I missed. They could have told me what I missed. So that is going to be there in medicine, which we will not lose. So that's a long answer to your short question.
Thank you very much. Any other questions? Well, thank you. Yeah. Sorry, Dr. Khabir.
Thank you so much, Professor Sanjay, for your talk. I wanted to ask how the attrition rate affects satisfaction, and has it changed in your, what kind of attrition rate you have in your center, and especially those people who are responsible for the repute of your center. What do you do as a leader to retain them, especially the front desk people, the nurses? Thank you.
That's an important question. Yes, you're absolutely right. The attrition rate is tremendous. You spend a lot, each of us spends a lot of time training the people at the front desk, making them learn which is an emergency, which is not an emergency. Triage nurses, technicians, the technical training, we invest a lot in them. And then within a year, if they are offered another job with a higher pay, they're going to go. What's it that's keeping them? The people that work should be there at least for the next 5 to 7 years to pay back the amount of time you invest in them. Of course, we would love them to have them for 20 plus years. I have in my clinic some technicians and the front desk who have been there for more than 20 years. Why? They are not being paid. The person at Walmart, the cashier at Walmart gets paid more than the front desk person in my clinic. What keeps them there? It's the satisfaction. So motivating them, thanking them. I go around, Duke doesn't pay me for doing this. This is my job because I spend more time with them than I spend with my family sometimes. Because I'm spending 9 hours there in the clinic. They are my second family. If they are not happy, I'm not happy. They are disgruntled, they're upset, they're angry. It ultimately affects me. If they are smiling, they are happy. It makes my life easier. So what did I do? I put off the TV in the waiting room and I put on 3 remote speakers in the waiting room with nice, soothing instrumental music. And now the patients are calm, the front desk is calm, nobody is stressed, everybody, the calm level suddenly increases. You do something to improve their life. Then they see that, oh, you know what? I'm being valued here. I'm not just somebody who comes in, works, and goes home. The chief is coming and talking to me. If they have a medical problem of their family member, I know everything about it. Why is that? Because I go there and ask them, you look worried today. What's going on? Let's chat. They are like shocked. The chief is coming to us and asking me what's going on. And all that they want to do is just pour out and just share with another human being their problems. And I can at least give a pair of ears to listen to them. So that makes a world of difference. They feel valued and their attrition rate is much lesser. Doctors, on the other hand, are different. They will move. A lot of doctors move from the Duke Eye Center, but many of the ones that were there, the original 12, many of them are still there. They move because of family reasons, relocation of things like that.